Hi, I'm Jared Gardner, and today we are going to talk about the basic patterns of melanoma. Melanoma is a huge topic, and there's so much, entire textbooks have been written about this, so much to discuss. But I want to go over some of the basic features that we see histologically that make us think about melanoma when we're evaluating melanocytic lesions. I have a video about the basics of benign melanocytic nevi, and if you haven't watched that yet, I'll put a link in the top right corner of this video and also in the video description down below. That might be useful because we're going to talk about some of the ways that melanoma violates the rules that we usually see in benign nevi. So a few of the things that we look at, this is a little bit of an unusual melanoma to start with because of all the keratin up top. There's tons of dead keratin and scale, what we call scale, parakeratosis, with a lot of pigment in it up over top of the lesion. There's also some crust in there too, some serum. So this was an inflamed and irritated melanoma, but all of that crust actually made it look very much like an inflamed seborrheic keratosis to the dermatologist. I remember distinctly actually when I called to report the diagnosis in this case, and it was a long time ago, but I remember they were really surprised because it really looked so much like a seborrheic keratosis. And this is a good reminder of the importance of what we do as pathologists. We have an important job still because sometimes even very good dermatologists or very good clinicians of other sorts have difficulty distinguishing between different entities clinically, and we can often add value and help when we look at lesions microscopically. And again, this video is for educational purposes to help teach you, like all of my videos are. This is not a consultation. This doesn't replace the need to get a consultation. If you're not sure if it's a melanoma or not, get expert help. A lot rides on a diagnosis of melanoma versus nevus, and this is something that's very important and for patient care and legally, of course. So that's the main point. This is true again for all of my videos. These are for educational purposes and to help you learn about how we diagnose these things, but of course you have to use your own medical judgment and get help when you need it. So one of the first features I think that's useful when you look at melanoma, just like for nevi, start at low power, okay? Look at the lesion at 2x or 4x, whatever the lowest power objective is on your scope. Symmetry is a useful thing. Does the lesion, if you draw a line down the middle of it from top to bottom, if I go like this and make a line, is the left side a mirror image of the right side? Well, you might look at this and say, yeah, more or less, it kind of looks the same on both sides. But this is why it's important to not just look at the middle of the lesion. In fact, if I put down a slide and I see some obvious abnormality in the middle, I oftentimes will go make myself look out at the edges first because I know that I'll get so fixated on this obviously abnormal finding that sometimes it's easy to forget looking at the periphery of the biopsy, particularly on a broad shave biopsy. And you know, in the case where you have a basal cell or squamous cell carcinoma, say, we don't have that here, but if you have one of those, sometimes if you don't look at the edge, you might miss there may be a little melanoma out to the side. I've seen that happen a few times. So I try to always make myself look at the periphery, the normal looking stuff away from the main tumor in the middle. And then when I've determined that that's all clear, come back to the tumor. That way I don't get too fixated on the tumor and forget to check those edges, okay? So just a general tip for Dermpath. But look, as we go out here to the side, this may look like normal skin at first glance compared to what we were just looking at. But look closer. There are actually melanocytes in here, increased melanocytes. And you can see they're grayish brown. They have this kind of dirty grayish cytoplasm, which we often see in melanomas, but sometimes in nevi. There's a mitosis in here. There's really marked nuclear atypia. A lot of the features we're going to talk about throughout this video, but this is melanoma out here. So when you compare or contrast that rather, this doesn't look like much maybe, but here we have one side of the lesion that looks very different from the other side of the lesion. So asymmetrical lesions doesn't mean that they are always melanoma, but it's a warning sign and you should go look closer and think about the possibility of melanoma. And that's going to be true for all of the points that we discuss in this video. I'm going to talk to you about asymmetry, about Pagetoid spread, confluent growth, abnormal maturation or loss of maturation in the dermis, mitotic activity in the dermis, and nuclear atypia in the melanocytes. Those are kind of the main features, all of those together, that I think of for melanoma. The problem is that none of those features is perfect, okay? I can point to a benign nevus that has one of, I've seen all of those different features, usually by themselves, in nevi before. I've seen nevi that are asymmetric. I've seen nevi that have mitoses, or that have atypia, or that have apparently abnormal maturation in the dermis, okay? I've even seen pagetoid spread in nevi. So that's the problem, and that's what makes Dermpath, and particularly melanocytic Dermpath, hard, is that there are not easy rules or firm, hard and fast rules that you can use. All of the rules, I'm putting air quotes, you can't see it, but I'm putting air quotes around the word rules. All of the rules can be broken, okay? And you can also have melanomas that don't have some of the features that we're going to discuss today. Usually they'll have at least one or multiple of those features, but not always. They're not, some melanomas look symmetrical and are not asymmetric, okay? So I think it's important to just remember that these are general guidelines, and when you see these things, stop and think about melanoma, but you have to put the entire microscopic picture together, all the different data points, and you have to put together the clinical scenario and make sure it makes sense. Is it a 1-year-old baby? Then it's probably not a melanoma. It's not that little babies can't get melanomas. They are extremely rare, but it has been reported, okay? Is it a 90-year-old person and you think that this is a really large nevus on their scalp and they're really sun damaged? Well, could it be? Yeah, possibly, but there's a really good chance that you're dealing with a melanoma instead. So you have to use the clinical scenario and make sure that the diagnosis that you want to make makes sense. And that's true, I think, in all of pathology, particularly in Dermpath, particularly in melanocytic Dermpath. Okay, so that with all those caveats, let's go back to the features. So we talked about asymmetry, where one side of the lesion looks very different from the other side of the lesion. And I just recently learned, I'm reading a textbook right now about nevi and melanoma, and it's written by Guido Massi and Phil LeBlois, and it's a wonderful book. I'm not paid to say this, I just think it's really great. And one thing that they pointed out is that asymmetry of pigment, when you have a lot of pigment on one half of the lesion and not as much pigment on the other half of the lesion, that can also be a sign to make you wonder about the possibility of melanoma. So that's something I had not learned before, and I'm still learning new things about melanocytic lesions all the time. All right, so enough, you're probably saying enough of this low power stuff, show me high power. Well, you don't really need high power in this case to see that there is unbelievable amount of pagetoid spread, okay? Pagetoid spread refers to the scattering of melanocytes, which normally live in normal skin. The melanocytes normally live along the basal layer of the epidermis. Oh, I'm sorry, you can't see the basal layer on the video there. They normally live down here along the basal layer in normal skin. And if you need a refresher on normal skin histology, I've got a video on that too, and you can check that out. I'll put a link in the upper right-hand corner of this video as well, okay? And so that's where melanocytes normally live. And nevi, the melanocytes begin to come together and make nests. Those nests are also usually located down at the basal layer, at the bottom of the epidermis. When we start seeing a significant number of melanocytes scattering or spreading up into the upper reaches of the epidermis, into the spinous layer, or even up to the granular layer or beyond, we have to think about melanoma, okay? And we say pagetoid because it's the similar pattern that we see in Paget's disease of the nipple or an extramammary Paget's disease, where we have malignant glandular type epithelial cells that are scattering and spreading upwards into the epidermis. Also remember that other tumors can have pagetoid spread. Squamous cell carcinoma in situ is actually the most common tumor that I see in my practice with pagetoid spread. I see pagetoid spread in squamous cell carcinoma almost every day. And of course I see melanomas almost every day as well, but it's certainly a lot more frequent, I think, to see squames. Just keep that in mind, that not everything with pagetoid spread is necessarily melanoma, okay? It's not necessarily even melanocytic. There are other things that have pagetoid spread. But when we see a melanocytic lesion with lots of scattering of the melanocytes upwards, that's pagetoid spread. That's a very strong warning sign for melanoma. Now, irritated nevi sometimes can get occasional pagetoid cells, particularly in the middle of the lesion. But again, like this, it would be. I don't think I've ever seen a nevus that had this much pagetoid spread personally. And also, the other thing that can be helpful is as you look out to the side of the lesion. Here's the other side I didn't show you before. But if you see pagetoid spread and scattering of melanocytes And here we have some right here, some Pagetoid spread right in here. And we're way out at the edge, the periphery of the lesion. So that's also a strong warning sign, okay? So if you think it looks perfect for a nevus and there may be 1 or 2 Pagetoid cells in the middle, well, that might be just an irritated nevus, or acral nevi on acral skin sometimes have Pagetoid spread. And so do Spitz nevi sometimes, and Reed nevi. So again, there are lots of exceptions, but when you see tons of Pagetoid spread, when you see Pagetoid spread at the periphery of the lesion, those are worrying signs for melanoma, okay? And again, that's why I selected this case, because it's unbelievable amount of Pagetoid spread. And you know, one thing I'll point out is, unlike squamous cell carcinoma in situ, even when you have a florid amount of atypical melanocytes and Pagetoid spread, they don't usually fully replace the epidermis. I've seen occasional times where they can almost replace it or kind of consume it with large nests, and but you usually will have them intervened with their, see there's pink keratinocytes in between all of these nests and single Pagetoid cells, okay? And so that's a useful thing, that in squam in situ, you may have areas that look kind of like this, but you'll also have other areas, usually of full thickness epidermal atypia. And that's a useful clue on H&E to tell apart a squam in situ from melanoma, okay? And here again, it's an amazing amount of Pagetoid spread. The Pagetoid melanocytes are breaking through the epidermis here and kind of even coming out into the corneal layer. We don't always see that, but sometimes we do, okay? And while we have this, let's look closer and see the cytologic features. So obviously, cytologic atypia is something that we often see in melanomas, okay? And atypia can be a little bit hard to evaluate. And as Bruce Smoller, one of my mentors, said, atypia is in the eye of the beholder. And while some people might disagree with that, I think in my experience that's actually proven to be true. Sometimes things might seem atypical to me, and one of my colleagues might not think it looks cytologically atypical. And also it depends on the clinical context. Again, I've seen congenital nevi in young kids that have big cells that if you would put that cell in a junctional melanocytic lesion in the scalp of an 80-year-old sun-damaged person, I would say that's super atypical, severe atypia. But if you put it in a congenital nevus that's obviously benign in a baby, I would say, oh, that's just some random nuclear enlargement. So you do have to keep in mind that atypia can be somewhat subjective and the context matters. But I think here, even medical students and even junior trainees would agree these cells are really atypical. They're huge, way bigger than normal melanocytes. They're even bigger than the adjacent keratinocytes. They have very large nucleoli in the center, and people often talk about melanoma as having cherry red nucleoli, but actually all nucleoli tend to have a reddish color to them, and that's because there are proteins, ribosomal proteins, going in and fusing with ribosomal RNA within the nucleus. At least that's what I've been told, and that explains why there's more of that kind of reddish pink color to the nucleoli. But melanoma do often have big nucleoli, and they're often kind of that reddish color. And we can also see in this example here pleomorphism. We can see that some of the cells are very large, and whereas other tumor cells are smaller. So we have a variation of size and shape of multiple times. The largest tumor cell is multiple times bigger than the smallest tumor cell. We also, the chromatin pattern of melanoma, it can vary, but a lot of times it's kind of coarse or chunky chromatin, where you'll have areas that are pale and then blobs of darker chromatin. Sometimes it can be diffusely hyperchromatic, sometimes it can be very pale and vesicular, but a lot of times it's kind of a coarse chromatin pattern. Okay, so these are very atypical cells, and they are melanocytes. And you can see here that they're melanocytes. Melanocytes oftentimes in normal skin have a pink or gray cytoplasm with very little, if any, visible melanin pigment. And again, in my normal skin histology video, I talk about that to some extent. Melanocytic lesions oftentimes will have melanin pigment with them, but the melanin pigment is still usually prominent in the keratinocytes, not in the melanocytes. Melanocytes normally make melanin pigment and transfer it to adjacent keratinocytes in the basal layer. That's the normal physiology of melanocytes in the skin. Okay, but sometimes melanocytes can make pigment, and the pigment will build up in the cytoplasm of the melanocytes, both in nevi and in melanoma. Okay, so that's important because being able to tell pigment that is a melanocytic cell versus some other cell is really important, because sometimes that will impact your ability to decide if the tumor is actually invasive or something else. So when you have a really dense chunks of pigment, a lot of times that will indicate a cell like here in the dermis, look. these dense clumps of melanin pigment, these are actually melanophages. This is melanin that's fallen out of the epidermis into the dermis and is eaten up by macrophages. So usually really darkly pigmented cells tend to not be melanocytes, but there are some exceptions, and here's one example where you're starting to see some of the melanocytes picking up a fair amount or having a fair amount of melanin building up in their cytoplasm. Usually I would say when you see pigment in melanoma cells though, it looks like this kind of dusty or dirty brownish gray cytoplasm. So we have this kind of grayish cytoplasm that has little specks, little stipples of melanin pigment in the cytoplasm, okay? So I think that's pretty helpful, that grayish cytoplasm with little fine granules of melanin. You can see that in some examples of melanoma, okay? But again, all of this pigment down here, these are melanophages, not invasion. So even though this melanoma is really exuberant and there's tons of cells, almost all of it is in the epidermis. See, you can look down to the dermis and we see inflammation in the dermis, a host response, that the inflammation that's responding to this overlying tumor, but there's actually no invasion of melanoma past the basement membrane. Let's look here again as another example of cytologic atypia. If I can get it into focus here. Huge atypical melanocytes right along here, okay? And there's a mitosis too. Now, we'll talk about mitoses in a minute, but you have to be careful about mitoses in the epidermal portion of a melanocytic lesion, okay? The reason, it's not that they're not important there. There have been some recent studies that have shown that actually junctional mitoses are more frequently seen in melanoma than in nevi, but it's not totally specific, and part of the problem is that how do I know that that mitosis is in a melanocyte rather than a background keratinocyte? Because basal keratinocytes are supposed to divide, and to divide a cell needs to have mitoses. So just interpret mitoses in the epidermis with caution. Certainly if you start seeing a lot of them, think about melanoma, but don't let that be your sole feature. I mean, these very well may be in melanocytes, but it's oftentimes difficult to tell for sure, okay? So if that's the only thing worrying you is that you've seen a mitosis in the epidermis and otherwise the lesion looks like a nevus, stop and make sure that that's really in a melanocyte and look at the other features, but that by itself would not worry me too much. In this case, though, obviously we have atypia, we have pagetoid spread, asymmetry, all of these other bad things, and this is clearly a melanoma. But when we're counting mitoses for prognostic staging of melanomas, we do not count the mitoses that are in the in situ component, in the epidermis. We only count the mitoses that are in dermal invasive melanocytes, okay? And we'll talk more about that in a minute. So anyway, this is an example of a melanoma that shows marked cytologic atypia, an unbelievable amount of pagetoid spread, and asymmetry, all of which are features of melanoma. I would classify this probably as a superficial spreading melanoma. So there historically are four major subtypes of melanoma: superficial spreading, Acral Lentiginous, Lentigo maligna, and nodular. And now in modern times we've accepted a variety of additional patterns or subtypes that we see, but those are the four classic patterns. Those are useful because they all show different features, they have different clinical features, they often have different molecular features underneath them, but the individual subtype doesn't really impact the prognosis of the melanoma. The most important prognostic factor for melanoma is if it's invasive and how deep the invasion goes, the Breslow depth or Breslow thickness of the tumor, okay, which is the measurement in invasive melanomas. That's the most important prognostic factor for melanoma, regardless of what type of melanoma it is. But most of the subtyping is done kind of for historical reasons. I know plenty of dermatopathologists that do not usually provide a subtype. I still tend to, because the dermatologists and surgeons that I work with are still interested to know if it's a superficial spreading or lentigo maligna or acral lentiginous or whatever. So I usually will put those when I can. When I'm not sure of what subtype, then I just say unclassified. And that's just my personal approach to how I handle melanoma diagnosis in my practice. This is actually an acral lentiginous melanoma, and it is on acral skin, as you can see. And this melanoma on acral skin shows, again, a dramatic amount of pagetoid spread, okay? Lots of single melanocytes that are atypical and have kind of a grayish pink cytoplasm, and they're spreading all the way up, scattering all the way up into even all the way up to the granular layer and into the corneal layer, where they then die and get kind of trapped in the dead keratin. And you can see that there are also some nests that are pagetoid, whole nests that are breaking free from the basal layer of the skin and spreading upwards into the epidermis, okay? So some people describe this as a buckshot pattern also, where it looks like a shotgun shot upwards into the epidermis and sprayed individual little pellets of buckshot into the epidermis, okay? So that's, again, dramatic pagetoid spread. Remember that acral nevi sometimes will have pagetoid spread, and occasionally it can even be pronounced. But we see other things here. This is very cytologically atypical. We have really large nucleoli, kind of that, see if I can find it here. We have large atypical nuclei with prominent nucleoli. And look what we also have. Here's a nest that's actually down, I think, in the papillary dermis. And look what we have right in the middle. We have a mitosis. So dermal mitoses are another worrisome finding in melanocytic lesions, particularly if there are many mitoses, particularly if they are atypical mitotic figures like tripolar mitoses or asymmetric mitoses that look atypical, and also particularly if you see mitoses in the deep aspect, down in the deep dermal portion of a thick melanocytic lesion, okay? So I've definitely seen nevi on a regular basis that might have one mitosis, particularly in the superficial dermal portion of the lesion. But if you start seeing multiple mitoses, that's a time to stop and worry about melanoma, particularly if you have atypia, pagetoid spread, other features. If I have an atypical melanocytic lesion that I'm worried about melanoma, and then I see a dermal mitosis, that usually is kind of a feature that will push me over the edge into deciding, yes, this is melanoma. If I'm on the line and uncertain, having a mitosis in addition to other atypical features is very helpful. I mean, obviously, a case like this, once you have some experience in Dermpath, this, from the second you put this slide on the scope, you said this is going to be a melanoma. It's a pretty easy, really classic dramatic example, okay? And here, another thing we can look at this case and talk about is maturation, okay? Maturation is somewhat of a complicated topic to talk about. Let's go to lower power here. What we generally see in nevi, and again, go back to the nevus video if you've not watched it yet, is we see that as when we have a melanocytic lesion that has a dermal component, either a compound nevus or an intradermal nevus. If we look at the melanocytes in the superficial dermis, the papillary dermis, we'll usually find larger melanocytes that have more abundant cytoplasm and are arranged in larger nests. As we go deeper down into the dermis, the melanocytes themselves get smaller, they have less cytoplasm, their nuclei tend to get smaller, and the nests that they're in tend to get smaller, and even the cells start getting arranged as little single cells that trickle down into the dermis. So that pattern is called maturation or zonation, some people say. And the term maturation goes all the way back to, I believe, Dr. Una in the late 1800s came up with this idea, and the theory was that nevi start as junctional things and then move down into the dermis and mature. And we now, I think, biologically understand that that's not actually what's happening in nevi, but the term maturation is so widely used and understood in Dermpath that we still use it even though it's probably not technically accurate at a scientific level, okay? But it certainly is a useful tool morphologically to determine if you're dealing with, or to one of the points that you can use to determine if you're dealing with a melanoma or a nevus. So at first glance, this lesion may seem to have maturation. It's got large nests of large cells up here, and as you go deeper, the nests and the cells seem to get a little bit smaller. So this is again why maturation, even though we find it useful, it's sometimes kind of complicated because it's not as easy to evaluate, particularly for beginning pathologists. But I'll tell you one thing that I find really helpful is, obviously, if you see large nests of large cells down at the deep part of a lesion, that is one feature that might be worrisome for melanoma, and I'll go look closer for other things. But what we can see here, this again is obvious. There's cytologic atypia, very atypical melanocytes here. They're large. They have kind of hyperchromasia in some of them. We see mitotic figures, multiple. Here's a mitosis over here. But look, as we go down, even though the nests get smaller, the melanocytes are still very large and atypical, and they have nucleoli even down here at the deep part. I feel like that's one helpful thing. If I have a lesion that looks kind of funny, and I look down at the deepest portion of the lesion, the deepest portion of the melanocytic lesion in the deep dermis or deeper down in the dermis, and look at the nuclei. If the nuclei are still large and there are still prominent nucleoli even down deep, to me that's a sign that maybe the lesion doesn't have normal maturation. So even though it does seem to get a little, the cells get a little smaller and the nests get smaller, we still have pretty atypical cells and pretty large cells down here at the deep aspect of the lesion. And also, you may have noticed we passed over a couple mitoses. Here's one right here again. So we have multiple dermal mitoses in the dermal melanocytes in this case. And it can also be a little challenging sometimes to tell if the dermal melanocytes are, the dermal mitoses are actually in melanocytes or not. If you see, sometimes mitoses will, if there's a lot of inflammation, you can see mitotic figures in the inflammatory cells or in dividing endothelial cells if there's some granulation tissue or reactive vessels around. But here, when you see a mitosis that's right in the middle of a nest of melanocytes, there's no doubt about that. That's a mitosis in a dermal melanocyte, and that is a very worrisome sign for melanoma when there are many of them and when there are other atypical features present. So again, here we are down at the deepest aspect of the lesion, and as we look along, we still see pretty large, very atypical cells even down here at the deep aspect. And I think here's an area where, I thought somewhere on here there was a good area that, yeah, here's an area I think that's helpful too. See this, looking in the papillary dermis here, we see large nests of large cells, and as we go down, they still tend to be pretty large even as we move down into the dermis. Still large cells, still large nests. They do start to trickle out down here, and again, that could give you the impression that there's normal maturation at low power, but at higher power, these cells are clearly atypical. Big nucleoli, large nuclei, atypical nuclei, even down at the deep aspect of the lesion. So maturation is a helpful feature, but it only works on lesions where you have a dermal component of melanocytes. You can't use the word maturation when you're talking about junctional nevus versus melanoma in situ, okay? So in those kinds of cases, you only can look at the epidermal features, the features that melanocytic lesions have in the epidermis. Maturation only works if there's a dermal component, okay? So you can't use that rule when you're trying to decide if something's a melanoma in situ or not, all right? So that's another example of atypia, of Pagetoid spread, and of abnormal maturation in a melanoma. Now, here is a scar. This is a dermal scar, and the reason is that this was a melanoma that was biopsied, and then the margins were positive, and they came back and they did a wide local excision around it. And here's the residual melanoma that's left over here. And again, this is just an example of really dramatic Pagetoid spread with lots of atypical melanocytes scattering upwards into the superficial aspect of the epidermis. And this melanoma doesn't have much pigment at all, right? The cells are very pale, grayish cytoplasm, and this is a little bit older slide that's a touch faded, but still you can tell that there's really no melanin pigment production here, okay? So when the melanin pigment is present, it's helpful. And actually, even though I just said that, now I've been proven wrong, when you look really close, I don't know if it'll pick up on the video, there are actually really tiny little bits and pieces of melanin in some of these cells, very subtle and focal. And if you have doubts in a case like this, and you're not sure if these are melanocytes or not, you know it's Pagetoid, you know it's atypical, you know it must be malignant, but you're not sure, are these melanocytes or could this be Paget's disease? Could this be squam in situ? I think much of the time you can decide that on H&E alone. But when you need help, you can use melanocytic markers to help sort out that differential. So MART1 or SOX10 will stain the melanocytes, but will be negative in Pagetoid squamous cell carcinoma in situ and in Paget's disease of the nipple or extramammary Paget's disease. So you can use a variety of different immunostains to help you. Here again is a nice example of nuclear atypia with a really large melanocyte with a huge nucleolus. And then that's a nice example of Pagetoid spread. So this is another example of a superficial spreading pattern of melanoma. In this case, it was actually just melanoma in situ. And most of the time for melanoma in situ, I just say melanoma in situ and I don't actually put down a subtype, with the exception of the Lentigo maligna subtype, because those do tend to spread farther to the side and oftentimes require a wider margin or more stages on Mohs surgery if Mohs is being used. And so I think a lot of times the treating physicians like to know that information. So when I have Lentigo maligna, even on a melanoma in situ, I do tend to say that. And again, that's just my personal practice. All right, so here's another example of a melanoma on acral skin. And this really dark stuff here, by the way, this is just an air bubble underneath the slide that's right on top of the keratinocytes. It's not important. So if you're a beginner watching this, just know that's all that is. If you see that real dark line, it's not melanin. This stuff, the dark stuff you're seeing here, that's actually melanin. Okay, so here's an acro lesion, a large acro lesion on the sole of the foot. Okay. Well, we can see right here, actually, in the dermis, there's a nevus here. So this nevus has probably been present for a long time. All of these cells in the dermis, they're maturing nicely. They're starting up here and then going down and maturing and getting smaller. But in the epidermis, we see something else going on. We see some Pagetoid spread, which you can have in acral nevi, but we also see pretty large atypical melanocytes here. And in acral sites, what I like to see to make a diagnosis of acral lentiginous melanoma, ideally I like to see severe cytologic atypia and confluent growth. Now, we don't always get that, and sometimes the edges of a large acral lentiginous melanoma, if they biopsy near the edge, it can sometimes be very subtle. And so this is why on acral pigmented lesions, I really like to know the size of the lesion. If they're biopsying a really tiny lesion and the biopsy probably is showing most of what's of the lesion clinically, it's lesion's 3 or 4 millimeters and they've done a shave biopsy or a punch biopsy, well, in that case, then I feel pretty reassured that what I'm dealing with is probably not a melanoma. It's not that you cannot have small melanomas, you can, but on acral skin, the thing that worries me is that I'm getting a small biopsy of a large lesion. So if you're a dermatologist watching this, or a family doc, or anybody who does biopsies, please, please, please remember this one thing. If you're going to biopsy melanocytic lesions, either try to biopsy the whole lesion, or if you think that you need to take a partial biopsy of a big lesion, sometimes that's needed. I would caution against it unless you absolutely have to. But in that case, please tell the pathologist, put it on the requisition sheet, this is a partial biopsy of a 3-centimeter plaque on the bottom of the foot that's black. That is incredibly helpful information for us and can help save the patient and everyone involved from a potential misdiagnosis. Okay. So on acral melanocytic things, I like to know the size and make sure I'm not missing something. In any case, this is a big excision because this was already a biopsy-proven melanoma. So there was nevus there, but there's also melanoma. Melanomas arise in nevi on a relatively regular basis. I mean, the risk of a nevus turning to melanoma is very low. Most people have multiple nevi, and most people do not ever get melanoma. So the risk is low, but we do see melanoma next to nevi on a regular basis in my practice. Okay? The reason I'm showing this is that acral lentiginous melanoma is the best type of melanoma to show confluent growth, okay? So confluent growth is a feature that we look at as worrisome in a melanocytic lesion. Nevi usually have individual either nests or sometimes single melanocytes in the epidermal junction at the basal layer, but they're spaced out from one another by normal intervening keratinocytes, okay? That's the way normal melanocytes grow, and that's the way nevi tend to grow. Melanomas sometimes, though, will overgrow in the epidermis, and sometimes they spread upwards, and that's Pagetoid spread, and sometimes they spread out to the sides and replace the basal layer with melanocytes. They push the keratinocytes out of the way, and we call that confluence or confluent growth. And that feature is a helpful sign for melanoma, but it can be kind of challenging to evaluate microscopically. It's easy for us in Dermpath to talk about that feature, but it's actually kind of hard, I think, to pick up on how to diagnose it. So I think that acral melanomas usually show really dramatic confluent growth, and so they're a good place to start when we're talking about this pattern, okay? So here, and this, again, I told you earlier that usually the really darkly pigmented cells are not melanocytes. Well, Here's me being proven wrong. Sometimes they are. I feel like acral melanomas have a tendency to have more pigment. I don't know if that's really true, but in my experience, they seem to more often be darkly pigmented melanocytes than other types of melanomas. So up here we have some pagetoid cells, and along the basal layer here, these guys, even though they have a lot of pigment, these are actually all melanocytes, and if you did a stain for MART1 or SOX10, they'd almost all be positive. And they've basically completely replaced the basal layer. Like, there are almost no keratinocytes left in here. All you see are melanocytes with maybe there's a rare keratinocyte left in here, but almost the entire basal layer is replaced by atypical melanocytes. That's called confluent growth, and that's a worrisome sign for melanoma, particularly if it's really prominent. Sometimes in irritated nevi, or particularly nevi that have been biopsied and then regrown over top of the scar, recurrent nevi, they can have pretty striking confluent growth and yet are still benign. So again, every single rule I'm going to teach you here today is going to have possible times when it can be broken, okay? So recurrent nevi can look and also really irritated or scratched, excoriated nevi that have regrown into the epidermis over top of the area of injury. They can have what looks like confluent growth. But here we have marked cytologic atypia and other features for melanoma. But this solid line of melanocytes replacing the basal layer, that's confluent growth, and that's a really helpful feature for melanoma, okay? This, I think, is like the best example of confluent growth in my collection. Let's see if I can find the other area without the slide falling here. I'm going to turn it around. Here. This is a really great example, really dramatic example. So the confluent growth starts down here in the reedy ridges and moves all the way up the side of the reedy, all the way along here. So down here the melanocytes don't have much pigment, up here they do, but they're all melanocytes, and if you did a stain it would prove that. And you can see a solid line of atypical melanocytes basically replacing the entire basal layer of the epidermis, okay? So that's confluent growth, and that is a really helpful feature when it's present for melanoma. Now, oftentimes melanomas don't have confluent growth, so just because it doesn't have confluent growth doesn't mean that it's benign, but if you see confluent growth, you should be really worried about the possibility of melanoma, okay? And again, these have really large nucleoli. They're atypical cytologically. It's a little hard to see the nuclei and the nuclear features in some of them because of all the extra melanin pigment that they have, but they're quite atypical. All right. And one thing that's a helpful clue for confluent growth is this. What's happening here is the epidermis looks like it's separating from the dermis. It's like a blister almost, like a little subepidermal cleft or separation. Looks almost like what we see in small blisters in inflammatory bullous dermatoses. So if you see a blister, again, I'm using air quotes here. If you see a blister, or what looks like a blister or a cleft, or like the epidermis is unzipping itself from the underlying dermis in the midst of a melanocytic lesion, that you have to think about melanoma until you can prove otherwise, because that's a worrisome sign. And what this is an artifact, and my understanding of why this probably happens is that there are so many melanocytes growing along here, pushing the keratinocytes out of the way, that when we process the tissue in formalin and the other chemicals we use to fix the tissue, there's sometimes some shrinkage of the tissue, and the epidermis normally is held tightly to the dermis by the hemidesmosomes and all of their adhesion molecules that hook onto the basement membrane. We don't have that here because most of the keratinocytes have been pushed out of the way by melanocytes. Melanocytes do not have those same adhesion molecules. They do not attach down to the basement membrane, and so the epidermis starts to cleft and lift away. So this is not like an actual blister in the patient. It's an artifact that we see microscopically, kind of like the clefting artifact that we see in basal cell carcinomas. It's an artifact, but it's a useful artifact because it's a clue to confluent growth, and it's a clue to melanoma in the context of a melanocytic lesion. Okay, so when you see that, now I've seen times where there are splits like this that are just due to tears in the tissue or something, so it's not that every time you see this cleft it's always melanoma, but you should really stop and think about melanoma when you see this sign right here, the unzipping sign or the melanocytic blistering sign. It's an artifact that's really useful, okay? So confluent growth, like I said, is often not nearly as dramatic as we see in this case of acromelanoma. But I think this is a good example of a really classic, really ideal example of confluence. And here's more of it over here with that same look again, that blistering artifact, or that unzipping sign where the epidermis and the dermis are starting to separate from one another because of overgrowth of the melanocytes, replacing the basal layer keratinocytes. Another feature that you can use when you're trying to decide if something's confluent is look for the adnexal structures. And this again is particularly true in acral lentiginous melanomas. They have this really strong tendency to grow down the eccrine ducts. And so here's an eccrine duct, and the way I can tell is it's a little structure made of keratinocyte-like cells, and in the center there's a little tiny hole that you can barely see here, and it's lined by a little pink cuticle. You can just barely see it, so we're cut kind of at an angle, so you can't see a perfect empty lumen in the middle. But this is a duct, and look what these are the epithelial cells of the duct that look a lot like keratinocytes. And then around the outside we have large atypical melanocytes completely wrapping and replacing the basal layer of the ductal epithelial cells. So sometimes when you're not sure if there's confluent growth in the epidermis, looking and seeing if you're having single cell confluent growth down the eccrine ducts or down hair follicles can be incredibly useful. And I've definitely had times where that feature was what helped me make the diagnosis of melanoma. And this case I think has some other examples. Let me find another place. Here's another duct. And now that one you definitely can see there's a nice lumen in the middle there. So this is an eccrine duct. And again, it's not completely wrapped by atypical melanocytes, but you can definitely see single atypical melanocytes that are spreading down into the duct and replacing the basal layer. And sometimes they can be so florid that they can replace most of the epithelial cells in the sweat duct. Okay, and in that case they can kind of be mistaken for invasion. Actually, you can look at this here. You could say, oh, this is a nest of invasive melanoma. Well, actually, there are probably some keratinocytes, or I'm sorry, some epithelial cells left in there. So this is probably actually in situ spread down a duct. So you wouldn't want to measure that as an invasive area in a melanoma. Now, this melanoma has other areas like this that are definitely invasive. We see atypical melanocytes that are invading the dermis. And again, it's a little hard here because look at all the pigment, and a lot of these really darkly pigmented cells are actually melanophages. Whereas these cells that have a little bit more of that dirty grayish cytoplasm, even though they have some pigment, they're not nearly these are like so dark brown that they almost look black. These are melanophages, these are melanocytes. Sometimes the nuclear features can help you, sometimes seeing the grayish cytoplasm can help. If you're really struggling to tell if the dermal cells are melanocytes versus melanophages, do an immunostain, and that can really help solve the problem. And that's really important because if they're just melanophages, then you might have a melanoma in situ but no invasive growth. And if they're melanoma cells in the dermis, then you have invasion, and that's going to change the treatment and potentially change the prognosis for the patient. So it's important to make that distinction. Here's another example of a duct cut kind of funny where here's the epithelial cells in the middle and atypical melanocytes are on the outside. One other thing I guess that I'll say before we move on about confluent growth is that it doesn't always work so clearly as I showed in the previous area. But what I start to worry about is that a lot of times nevi will have nests of melanocytes down the tips of redi. And when I start to see single melanocytes crawling up in between the redi, the inter-redi space, the area over top of the dermal papilla, or the papillae, if we're saying multiple, if you start to see a lot of melanocytes filling this space in here, that starts to worry me that we're getting into confluent growth. Now that's kind of a subtle thing that can be hard to interpret. I definitely see some single melanocytes in the inner redi space in benign nevi on a regular basis. But if that's one thing I look for, if I'm having a hard time with a lesion, I start looking and seeing, are there very many cells growing in that space? Because again, that's the idea that the melanocytes are starting to get a little bit too rambunctious and are growing upwards and starting to replace parts of the basal layer. So like here, look at this. We're starting to see single melanocytes kind of coming in here. By itself, that's not enough for melanoma, I think, but it's a sign that makes me start to wonder and worry a little bit. And then over here, I know it's upside down, but you can again see complete replacement of the basal layer by atypical melanocytes. And that's obvious confluent growth. So I hope that helps you understand confluence a little bit better. And I admit it's kind of a tricky topic, but if you do an immunostain, what it'll look like is like a kid took a crayon and colored a solid line right along the basal layer. It just completely replaces most of the basal layer of the epidermis when you have really dramatic confluence. Now look, here's an example where the entire epidermis is basically missing, and this is also from acral scan. This was a large, worrisome lesion clinically. A punch biopsy was done because it was so large that it wouldn't have been feasible to remove the whole thing. Thankfully, the dermatologist was very clear about that and said that this was a partial biopsy of a large, worrisome lesion. And here you can see one little fragment of epidermis, but it's totally detached. So it's hard to evaluate a melanocytic lesion when the whole epidermis is gone, right? Because I can't look for Pagetoid spread, really. I can't look for confluent growth. But when I see an atypical melanocytic lesion, this is not a common finding, but when I see something like this, that instantly worries me that maybe there's confluent growth that's so confluent that the whole epidermis has artifactually detached during processing of the tissue and is floated away. And look, we can see atypical melanocytes right in this space where the basal layer would have been, but we just can't see any epidermis with it. Certainly there's cytologic atypia down in the dermal component to some degree, but the cells also kind of have a little bit of a nevoid appearance. They kind of have a nevus-like look, so it could be really challenging. And here it matters because look how thick this lesion is. It goes down into the dermis, so if this is melanoma versus a nevus, that's a big difference for the patient here. But look what we have right here. It's a little bit hard to see on this section, but right here is a sweat duct. And there's a little tiny lumen in the middle. And if I did a keratin stain, those cells in the center would stain. And around the outside, we have complete wrapping of the duct with very atypical melanocytes. So this is confluent growth all the way down. And we're way down in the dermis. Look at this. It's really amazing to me how acral melanomas tend to do this. We're way down here, and we have actually, this is not invasive, but melanoma in situ within the sweat duct epithelium. So here, that actually is a feature that would really be helpful in confirming the diagnosis. But look, the other piece actually shows us that what we suspected is exactly what's happening. Here is the melanocytic lesion, and you can see this cleft, this split, the blister here, which is artifactual from the confluent growth of melanocytes along the dermal epidermal junction. And there's cytologic atypia, there are really hyperchromatic atypical melanocytes, and there's Pagetoid spread, lots of Pagetoid spread. And if we look over here to the side, this area is not quite as dramatic, but we do begin to see some single cells moving up in the inner reedy space, along the basal layer in the space between reedy ridges. And look what else we see. Here's an acrosyringium. This is the swirly, spirally opening of where the Eccrine duct deposits sweat out onto the skin surface. And it's the best place to see them is in acral skin. They're really dramatic there. And look what we have right below it. We have the sweat duct. Here's the lumen of the duct right here. It's got a little hole there. There's a little pink lining. And what's this? All melanoma cells completely replacing the basal layer and most of the epithelium of the sweat duct. So this is what we saw in the other piece. This is what it looks like up at the top. The cells have tracked all the way down that duct, way down into the deep dermis. And so again, finding that is a really helpful clue for melanoma. So all of this here is invasive melanoma. And I've even occasionally, I don't think this case has it, but I've even occasionally seen melanoma in situ all the way down in the eccrine coils, way down. And it's important, again, to recognize if it's actually in the sweat ducts or glands, that's in situ, that's not invasion. You don't want to measure that, okay? That will give you a deeper Breslow than is actually real. Here's an example, again, of complete separation of the epidermis from the dermis, a complete, looks like a subepidermal blister, but it's artifact due to the confluent melanocyte growth. Atypical melanocytes in the dermis. And this is the one where we have dramatic in situ melanoma all the way down here. Here's the duct, cut kind of at a funny angle, so that's why it looks like it's got little septations there. It's actually just a swirly kind of spiral of the duct that's cut funny. all of this as melanoma in situ, replacing it. And this case is a little odd that in addition to melanoma in situ, there actually are single cells of invasive melanoma that have also tracked along the duct out in the dermis, though. They're out in the dermis outside of the epithelium. So there's both in situ and invasive melanoma around these ducts, which is kind of weird, but it's a really, really great example, though, of how dramatically you can have melanoma in situ spread down ducts in a confluent fashion, and that can really help make the diagnosis of melanoma in challenging cases. So Breslow depth is normally measured, the way we measure it is we measure from the top of the granular layer, so not the top of the corneal layer, but the top of the granular layer, and we measure all the way down to the deepest part of melanoma. So we'd start here, we measure down here, and usually we have an eyepiece that you can't see on the screen, but that we can see here sitting at the microscope. It's a micrometer in the ocular of the microscope that lets us measure, and we report it in millimeters. And in a case like this where there's an artifactual split, I would make a measurement from here to here, and I might measure several areas. This area over here actually is probably deeper. And in fact, since we had stuff down deep, we probably could measure all the way here, but that's a little bit more complicated. Just for the point of it, say this was the deepest part of the lesion, you would start at the granular layer, you would go down to the deepest place in the lesion, and if you have an artifact like this, a little split, subtract that amount out, because that's not really there in the patient. So if that might be a little tiny area that it won't really change much, but I usually will subtract that out if there's an artifact like that. Okay, so you measure from the top of the granular layer to the deepest point of invasion. And again, stuff like this is not usually seen in melanoma. It's kind of complicated, so we won't really go into how to deal with that. All right, but anyway, that's the basics of Breslow. That's the basics of confluent growth. A really good example. Now, this is changing gears a little bit. Here we have a biopsy of a pigmented lesion from the face of an elderly person. And you can tell it's probably the face because there's lots of large sebaceous glands and prominent hair follicles, okay? So as patients age, they tend to get prominent sebaceous glands and sebaceous hyperplasia on their face. But this is a dark lesion and the patient's old and sun damaged, okay? So clinically, they're concerned, is this a lentigo or a seborrheic keratosis, or is this an atypical nevus, or is this a melanoma? On the sun-damaged face of old people, my thought process is, if I see melanocytes there, I want to think about melanoma until I can prove that it's not. It's not that you can't have nevi on the face of old sun-damaged people, you can, but it's far more worrisome that I'm going to miss a melanoma if I'm not being cautious, because sometimes the melanomas that occur on sun-damaged elderly skin, particularly on the head and neck, can be very subtle at first glance. And so this type of melanoma is called Lentigo maligna, and it's called that because it looks a lot like solar lentigo clinically, but it behaves, if you leave it alone for many years, it will often behave badly. Sometimes it can behave badly even more rapidly, but a lot of times it will grow for a long time and then eventually become aggressive. So what we see in this case, there's a lot of pigment, right? Well, solar lentigo would look like that too. It can have elongated redi that are hyperpigmented. So when you see these, it's important to look a little more closely. If you see nests or a significant number of atypical melanocytes, you should be very worried about the possibility of melanoma in situ, okay, Lentigo maligna. And one thing that helps me is if I see this, I see kind of a jumbling of grayish looking cells along the basal layer. And it can be quite hard in cases that have a lot of pigment like this one. But here, when I start seeing an increased number of cells that are kind of large and have gray cytoplasm, that worries me. Now, if that's all I had here, doing an immunostain would be potentially very useful. And I personally like to use SOX10, and I like the red chromogen if you're able to have that, because it will help you in cases like this where there's lots of brown pigment. It'll help you to distinguish what's true staining of melanocyte nuclei versus background pigment, okay? But if you don't have that, MITF also works. Although I only personally like to use MITF for melanoma in situ, and I don't ever like to use it for invasive melanoma or metastatic melanoma because it's relatively non-specific in my experience and it will often stain histiocytes. So if you have MITF, I think it works okay for melanoma in situ, but I don't like to use it for melanoma in any other context personally. I think it's actually kind of dangerous to look at lymph nodes or distant mets and try to use MITF there. So anyway, we can have another video about melanocytic immunostains, but I personally like SOX10. MART1's okay too, but it will stain the dendritic processes of melanocytes, and it can tend to make you overinterpret how many melanocytes are there. So see down here, we're starting to see actually little clusters of single melanocytes, even though they're darkly pigmented or blended in with darkly pigmented keratinocytes, there probably are melanocytes down here. And an immunostain indeed actually confirmed that. You can see here we're starting to get little clusters. So again, what I'm showing you though on H&E here is kind of challenging. But the reason I'm going to show you this one is A, so that you remember that lentigo maligna can be very subtle sometimes and hard to tell. And B, there are some clues that help. Number one, look down the adnexa. Look at this. This is a hair follicle, and what are all these gray atypical cells? This is all melanoma. These are melanoma in situ cells. They're not nearly as pigmented as the ones at the junction, but they're growing all the way down, replacing the basal layer of the hair follicle, even spreading out into the sebaceous glands, completely in confluent growth pattern all the way down into this follicle. Look, we're still going. Down here, all of that stuff, all melanoma in situ. All of this melanoma in situ spreading out into a sebaceous gland. Now, sometimes you can see nests of melanocytes like in congenital nevi that are in the middle of a sebaceous gland or a hair follicle, but when you see single cell growth of atypical melanocytes down a hair follicle or down sweat ducts replacing the basal layer, that's a worrisome sign, particularly if you're looking at a pigmented melanocytic lesion from elderly sun-damaged skin. And look, you can see the same thing happening over here. It's not nearly as dramatic, but there are atypical melanocytes spreading down here and spreading over here. And so this is extra evidence of confluent growth. The lentigo maligna type of melanoma in situ doesn't have as dramatic of confluent growth much of the time. It's often kind of skippy growth where you'll see nests and single cells and then spaces with very little melanocytes and then more melanocytes, and it keeps kind of skipping all the way along, and it's usually kind of broad and will go from one end of the biopsy to the other oftentimes. Let's look at this piece down here. So here again is an example of a hair follicle and sebaceous gland with melanoma in situ tracking down into the adnexal epithelium. And here, this is more obvious. Here at the junction, we actually are starting to see nests and zones of confluent growth of the melanocytes. And once if you think you've got a solar lentigo, but you start seeing nests, actual nests of melanocytes, is not a solar lentigo. There may be a solar lentigo there also, but you have to think, once you have nests of melanocytes, you have a melanocytic lesion. Either it's a nevus, and maybe this person's had a little nevus there their whole life, and now they're old and sun damaged, or it's a melanoma. And so that's the kind of time where you gotta be really careful. And I personally find that immunostains can be helpful, although you have to learn how to use them because sun-damaged skin tends to have an increased number of kind of large melanocytes as a kind of melanocytic hyperplasia that gets induced by chronic UV exposure from the sun. And so you do have to be careful. Any old sun-damaged person is going to have more melanocytes and larger melanocytes than a younger non-sun damaged person. So you have to get used to how to interpret the immunostains in that setting. And if you're watching this and say you're in private practice and don't see a lot of Dermpath, take some skin from a basal cell or squamous cell carcinoma excision where you know there's not probably going to be any melanoma, just background skin, and do a SOX10 stain on a few cases to get an idea of, oh wow, this is the density of melanocytes that you see a lot of times in old sun-damaged skin. So I think that's helpful, and that can give you kind of a threshold or help you set your threshold for what is an allowable amount of melanocytes versus what's worrisome. I think the most important thing to me is if I do see zones of confluence, if I see patchy, skippy areas, if I see nests, and also if I see atypia, all those things can help me. So this is a lentigo maligna. It's all melanoma in situ in this case, and it's the lentigo maligna pattern. And these often are kind of broad and spread widely, and so it can be sometimes hard to get clear margins on them. And here's an example. It's not from the same case, but here's a nice example actually of the staining that you can see in lentigo maligna. Okay, this is actually a MART1 stain. It was, again, it's a stain I don't personally like to use very often looking for melanoma in situ. It's useful, I think, if you're looking at lymph nodes or metastatic lesions sometimes, or if you're looking for invasion, it can be helpful. For in situ, I prefer SOX10 personally, but it's still a good example. There's Pagetoid spread there. And look out here at the periphery. This is the reason that I think you gotta be a little careful when you use MART1. look what we have here. You can see there's strong staining of the cytoplasm, but look also, the melanocytes have little branching dendritic processes. That's what they normally use to feed melanin that they produce into their neighboring keratinocytes. But what happens here is it makes each single melanocyte looks a lot bigger and kind of broader than it is actually because of its cytoplasmic processes. So it can, the MART1 stain can make it look like there are more melanocytes there than there actually are. And the SOX10 or MITF nuclear stains will just show you the nucleus of each cell, and I think it's a little easier to kind of quantify how many cells are really there. But sometimes it still works because you have areas like this where there's obviously prominent Pagetoid spread, and the basal layer is basically completely replaced by atypical melanocytes. So this is a melanoma. And Lentigo maligna sometimes will have Pagetoid spread. Oftentimes it doesn't though, or has very little. So don't expect to always see Pagetoid spread for Lentigo maligna. And then here's an area where there's actually a couple little tiny nests of dermal invasion. And so the MART1 can help pick that up if you've got a lot of inflammation or background regression changes. MART1 can sometimes be helpful to show you subtle focal invasion that's kind of hiding in the background. So that's an example of what an immunostain. And again, I'll make a video in the future, I think, showing immunostains for melanocytic lesions in more detail. Now what I want to show for this lesion here, here's a melanoma. Again, we've got focal areas like this of confluent growth, areas where there's melanocytes replacing much of the basal layer and spreading in between rete. But why I want to show this case is because this is an example of regression change, okay? Regression is this kind of response that happens in the dermis under a melanoma, and the theory is that the melanoma invaded into that area of the dermis, and then the immune system destroyed part of the melanoma, and then kind of scar tissue and inflammation filled in that space. Now, in reality, just because an area looks like regression doesn't necessarily mean there used to be invasive melanoma there. Sometimes we see regression-like changes under melanoma in situ. In fact, I see that relatively often, and I'm not totally sure that every single one of those cases definitely had invasion that's now regressed. It may just be kind of a robust form of immune system host response against the tumor that's happened. But the point is, when I see this and see a significant amount of it, I like to report it. And it's one of the things that in the prognostic parameters that we often report for melanomas, although the significance is somewhat debatable. People have argued that it's a bad thing or that maybe it's a good thing, and there have been people that have argued back and forth. So if I see it, I usually will mention it in my report, but I think it's an important feature to recognize in melanomas. What we usually see in regression are three things. We see disorganized collagen bundles, collagen fibers. We see lymphocytic, we see inflammation, usually lymphocytes and sometimes histiocytes, and we often see pigment dropout or pigment incontinence, melanophages. So here, this disorganized pattern of collagen fibers with intermingled lymphocytes and occasional melanophages too, this is a good example of, I think, regression change. And sometimes there can be bunches of pigment in it. Sometimes it's very fibrotic. Sometimes it's very inflamed. It just kind of depends on the individual lesion and what stage it's at. But look at low power to give you an example. This is what the kind of normal dermis looks like in this person. You got the epidermis up top. The papillary dermis is normally filled with fine, delicate collagen fibers. And then the reticular dermis has big, thick bundles of collagen type 1. Okay? So that's kind of the normal dermis. And then look over here. See, that zone of the papillary dermis has been totally replaced by this disorganized fibrosis with thicker collagen bundles, but not quite as thick as the reticular dermal collagen. And they're very disorganized and they're intermingled with inflammation. And they're not usually quite as organized as scar. Sometimes it can be hard to tell apart scar from a previous biopsy versus regression change, okay? But it's a good thing to be familiar with and know what regression looks like. And also, regression's a little bit in the eye of the beholder too. Sometimes I'll think something looks like regression, and a colleague might say, well, I don't really think that's necessarily regression. It just kind of depends on your personal threshold. All right. And the last main type of melanoma we're going to talk about today is this one that I can't even get on the screen because it's so big. This is a nodular melanoma, right? It's a big nodule, huge nodule of tumor of melanoma. it's got a big ulcer at the top, and so ulceration is a bad prognostic feature for melanomas. Usually, melanomas that are ulcerated are also thick and have a lot of mitoses. So they usually have a high Breslow thickness and have mitotic activity. So they have other features that would be bad also. But so that's, I think, part of why ulceration is a bad sign, is that it indicates the tumor is growing really rapidly. And those tend to be tumors that end up being thick and end up having lots of mitoses. So we can see a big nodule of melanoma like this in any type of melanoma. You can see it in superficial spreading, in Lentigo maligna, in Acral Lentiginous. So just because there is a nodule of melanoma present does not mean that it is nodular type melanoma. And I think this is kind of confusing and a little frustrating. I thought it was frustrating when I learned it as a resident, and I still don't fully understand why it's so important that we have this strict rule. But what the rule is supposed to be is that a nodular melanoma, the invasive dermal component, okay, what we're seeing here, and the overlying in situ melanoma component are aligned with each other. You don't have in situ melanoma spreading out to the side beyond the invasive dermal component. So when we go to the edge of the nodule here, what we see is here's the invasive stuff. All this is invasive melanoma down here. And here's in situ melanoma up here. And look, the in situ stops right here, the invasion stops here. If it goes more than like 3 redi beyond the edge, if you can see in situ marching all the way out here, multiple redi ridges beyond the end of the dermal invasive component, then usually it's better to classify the lesion based on the pattern of what the in situ looks like. If there's lots of Pagetoid spread and large epithelioid cells, you could say it's a superficial spreading that just has a large nodule of invasive melanoma that's grown in it. Again, I don't personally understand why this semantic, to me this seems like semantics, and I don't understand the importance. I'm sure somebody much smarter than me will come and tell me why I'm wrong. But in any case, that's what the rules are supposed to be, that the in situ part doesn't go more than 3 redi, I think is the rule, beyond the edge of the invasive stuff. And if we look at the other edge of the lesion here on the other side, wherever it is, same thing. We have in situ stuff here, invasive stuff here, and the end of the lesion is right there. Sorry, it's kind of tipped at an angle, but here's the normal skin out to this. I dropped the slide into the microscope. All right. Here, we're looking at it kind of at an angle now. But there, this is the normal skin at the edge of the shave, and here's where the melanoma starts. And as you can tell, this is a large polypoid melanoma, huge, and it's bulging out of the top of the skin. And so we see these sometimes, and oftentimes these large nodular melanomas that are polypoid tend to be ulcerated. They tend to grow quickly. A lot of times they have very little pigment in them, and clinically they look like a big red ulcerated kind of friable nodule. They can look a lot like a pyogenic granuloma clinically. So that's why most of my colleagues in dermatology, if they see something that looks like a pyogenic granuloma, they'll usually biopsy it just to make sure they're not missing one of these kinds of lesions. And here's an example also of lack of maturation. Look at that. The whole dermis is filled with a uniform population of melanocytes. You don't even have to look at high power yet to see that you have huge, massive nests, and they're all packed really tightly together with very little intervening dermal collagen. And the nests up here are big and large, and as you go down, there's still huge nests the whole lesion through. It's like an entire solid sheet-like packing of nests together. Each nest is kind of a sheet, and all of the nests are packed closely together. And at the top of the lesion superficially and the deepest aspect of the lesion, it looks almost identical. Let's go to higher power and look. This one's got a little bit of a cracking artifact here in the midst of the tumor, but I think we can still make the point. We have really atypical melanocytes, big nucleoli, kind of vesicular chromatin in this case. If we look around, we'll start finding mitoses. Here's one right here. And again, usually big nodular melanomas like this with ulceration are usually going to have many mitoses. And in melanoma, we count the mitotic rate based on the dermal mitoses, the mitoses that are in the invasive melanoma component, and we count in 1 millimeter squared. And that's different on every microscope. We don't use the 10 high power fields like we use for many other tumors. So you have to know what the how many high power fields represent a millimeter square based on your microscope. And there are some calculations online using the field number of the objective and some other things to calculate how much area is in a high power field on your given scope. For my personal scope, it's like 3.5 high power fields. But again, you can't use that. You've got to go calculate it for your own microscope. And then you count the mitoses. And usually what I do is I'll find the area that looks most active, like, oh, here's an area. We've got at least 2 here. So we can find this area and we can say, okay, 1, 2 mitoses, and then I'll move to an adjacent high power field and I'll count there, and then another field, and I count 3.5 fields that way, and I add that together. And that's how I make my mitotic count. And for details about staging, and these change from time to time, you can look at the AJCC Cancer Staging Manual. And we just had a change back in January from the 7th edition to the 8th edition, and a few things changed. And so I'm not going to go really in depth into all the staging parameters here because they do change and their significance clinically changes from time to time. So whenever you're watching this video, you can go and look up the most recent version of the AJCC and see what the current staging practice is. Okay. So again, looking all the way here, we're now here down at the very bottom of the lesion, and just like at the top, we've got big nests filled with atypical cells, and look, mitosis, mitosis, we got mitoses and atypia everywhere, even down at the deep part of the lesion. Look, this looks even uglier than the top of the lesion. It's like larger and more atypical than the cells even at the top, and we're all the way down in the deep dermis. So this is a great example of abnormal maturation, where you have larger and even more atypical cells down at the deep aspect than you even had at the top, okay? So nodular melanoma. Now, one last thing I'll say is if you see something that looks like a nodular melanoma, like this kind of looks like one a little bit. Not nearly as big as the last one, but it's a little nodule of melanoma here in the dermis. And it's got lots of atypia and mitoses. But look what it doesn't have. It doesn't have any involvement of the epidermis. It's filling up the papillary dermis here and doesn't have any in situ component over top of it. So when you see that, you have to think about a metastatic lesion or a recurrent lesion. Melanoma that has been biopsied or surgically removed and then recurs in the scar, or satellite lesions, like little mini metastases that are on their way to the regional lymph node. We call those either satellites or in-transit metastases, or distant metastases. Melanoma likes to metastasize to the skin. It'll go to lymph nodes and other sites, but it also will tend to show up in the skin elsewhere on the body. When melanoma either recurs locally or has a satellite or metastasizes to the skin, it will usually fill the dermis, sometimes also the subcutis, but will not usually involve the epidermis. So the lack of an in situ component is a useful clue that you might be dealing with a metastatic melanoma. Okay, and in this case, this was actually a satellite, or I think an in-transit metastases. And the difference between that, in-transit met and satellite, is based on how far from the lesion, how big, and you can again look in the AJCC Cancer Manual. They both indicate the same thing. Melanoma is spreading from the primary tumor site into, or on its way towards the lymph node. And here there's a couple of nests pushed right up in the papillary dermis, but they're still not in the actual epidermis, okay? And so that's metastatic melanoma or a satellite lesion, can both look like this. And recurrent melanoma, if it's in the scar or right next to the scar of a previous melanoma surgery and you see a nodule of melanoma pop up, then that's recurrence. The reason it's important to know this pattern is, number one, if this is the first melanoma you're seeing from the patient, it's worth talking to the dermatologist and saying, hey, could this be a metastatic lesion? Sometimes patients will have had a lesion biopsied a long time ago and they forgot about it. And it's hard to believe, but it's true. Patients sometimes forget that they had cancer at one point, or forget that they had a biopsy that maybe got thrown away and not sent to the lab. I know that's shocking, but I have seen cases like that, and it's very tragic. Also, sometimes the patient has a known history they just haven't mentioned to their doctor, and sometimes we see something that looks like a metastasis, and after close full body skin exam, another area will be found that actually was the primary melanoma, or the primary melanoma may have been present, but it regressed away completely and only the metastasis is left, or the patient picked at it until it fell off their skin, so they kind of treated it with their own fingernail picking, and yet still it developed a metastasis. I've seen all of those different scenarios, so it's worth bringing up. I've also seen times where we just have a big nodular melanoma where either through the level of sectioning or due to a lot of ulceration, the in situ component's just not visualized, but clinically, after thorough workup, the most logical thing is that it's a big primary melanoma, even though we don't see an in situ component. So it's worth thinking about when you see melanoma in the dermis without an in situ component. Think about a metastasis and discuss with the surgeons or the dermatologists to see if that's a possibility. But just because it's missing an in situ component doesn't necessarily prove that it's a metastasis. Also, metastatic melanoma and recurrent melanoma sometimes can grow back up into the epidermis and mimic a primary melanoma. It can look like it has an in situ component. We call those epidermotropic mets. So this one doesn't have that, but this is a nice example of the pattern that you can see in metastatic melanoma. And if you don't believe me, that's melanoma on high power. There's lots of atypia and mitotic activity, and again, there was a known melanoma nearby. Okay, so remember that if there's not epidermal involvement, think about the possibility of a met or recurrence. The other important reason to know about that is if it's a metastasis or a satellite or a recurrent melanoma, you don't measure the depth of it, okay? The depth is only measured on the primary melanoma, so it doesn't matter how deep that is. That's not the prognostic impact. Is if it's actually a satellite lesion or a metastasis, that's what matters. Then the primary tumor depth doesn't really matter anymore once the melanoma started to spread, or it doesn't matter much at least. Now, the last thing I'll show is when you see this is what I often see when I see a distant metastasis of melanoma. I usually see normal skin up here, and then way down deep, a big, huge nodule of melanoma. Deep in the dermis, sometimes in the subcutis, a big nodule, a ball of melanoma, just sitting there in the dermis or subcutis. That's the pattern I usually see when I see metastatic melanoma in the skin. Okay, either a nodule in the dermis or subcutis, often deeper down, and not even always close to the epidermis. So that's the pattern of metastatic melanoma. So I think we've covered most of the main features. Remember, asymmetry, Pagetoid spread, confluent growth, marked cytologic atypia, abnormal maturation or absence of maturation in the dermis, mitotic activity in the dermis, particularly if it's abundant or atypical mitoses or deep mitoses, deep in the deep aspect. All of those are features histologically that should make you consider the possibility of melanoma, and that should give you a good starting point. And from there, there's a lifetime worth of learning to learn all the features. Like I said, I am still learning new stuff every day about melanocytic lesions. So I hope this at least gives you a good framework to start with, and I'll plan to make some more specific videos about different types of melanocytic lesions, both nevi and melanoma, in the future. Thanks so much for watching. If you like this, please click the like button and also leave comments below. Let me know what you like, what you don't like. Be kind though, please. And if you want me to make videos about different topics, please let me know what other things you're interested in. Thanks again for watching. Have a great day.